I want you to just picture the scene for a second. A Saturday afternoon, right? Freezing cold, pouring rain. And you are the one covering the emergency department trauma bay.
Always a fun shift.
Oh, absolutely. So the doors fly open, and the paramedics roll in a 25-year-old rugby player. He is in absolute agony.
Right.
And they give you the handover. Basically, he was at the bottom of a ruck. While he was down, several players, easily totaling hundreds of pounds, landed directly on his back.
Oh, wow.
Yeah. But crucially, his hip was flexed to exactly 90 degrees at the exact moment of impact.
Oh, right.
And the result is a posterior dislocation. The hip has literally been violently driven right out of the back of the socket.
Well, it is the absolute classic mechanism of injury. It's high energy, massive axial load being driven straight down the femur, right through a flexed hip.
Yeah, the physics of it are just brutal.
Exactly. The geometry of that position basically turns the femur into a battering ram against the posterior wall of the acetabulum. So you're the one standing there in the trauma bay looking at him. What is your very first thought?
Reduce it, fast. You have to get the hip back into the socket.
Right.
You need to stabilize the patient, administer muscle relaxants or maybe procedural sedation, and forcefully pull that femoral head back over the rim.
Yeah, to get the pressure off.
Exactly. To get the pressure off the joint, that is the immediate horizon.
Right. It's a true orthopedic emergency.
Mm-hmm.
But let me ask you this. Amidst all that adrenaline, the shouts in the trauma bay, the urgency of the reduction, what is your first thought about the next 20 years of this patient's life?
Honestly, I don't think that even registers. In the heat of that moment, your clinical horizon is exactly 20 minutes away, not 20 years.
Totally understandable.
You're thinking about the sedation wearing off, not, what this guy is going to be doing in his 40s.
And that is exactly the cognitive trap we fall into in acute medicine. And honestly, it's exactly what this deep dive is going to dismantle.
Right.
Last time we were together, we opened the hip up, we looked at the acute structures, the trauma, the immediate fixes. But today, we are going to watch it die.
Oh, okay. Grim.
Slowly. We are going to explore the 4 very distinct, agonizing ways this joint fails over decades.
Okay, lay out the roadmap for us.
We're looking at avascular necrosis, impingement, dysplasia. And finally, we will arrive at the operation we do when all of that has run its tragic course, when there's literally nothing left to replace.
You're talking about fusion, right? Arthrodesis,
Yeah.
locking the joint solid. That really is the absolute end of the line for a joint.
Fusion. Exactly.
Yeah.
Which, strangely enough, almost everyone inherently positions wrongly on the operating table.
Wait, really?
Oh, yeah. It sets a ticking time bomb for the rest of the patient's musculoskeletal system.
Wow. Okay, we definitely need to get into that.
We will get to that puzzle later. But first, we really need to go back to the trauma bay with our rugby player.
Okay, let's unpack this. Back to the 25-year-old. The hip is out. It's posterior.
Right.
The muscles are in spasm, holding it in that classic shortened, internally rotated position. If we are looking past the immediate reduction and we are thinking about the post-traumatic complications, what is the most common complication of a hip dislocation?
What's your gut instinct?
Well, if I'm thinking clinically, maybe it's post-traumatic arthritis or avascular necrosis.
Both good thoughts.
Or maybe a sciatic nerve injury from the femoral head pressing backward, or, I don't know, even recurrent dislocation because the ligaments are shredded.
Well, all of those are entirely valid, recognized sequelae. They all definitely happen. But if we look at the hard clinical realities, which is the most common?
If I have to reason this out based on what I actually see walking into the outpatient clinic on a Tuesday morning, I'd say post-traumatic arthritis.
Okay, what?
Because you see those patients years later, right? They come in limping, you pull up their radiograph, and you see the joint space is completely narrowed.
Right.
You see the osteophytes, the bone-on-bone mechanical wear and tear from the cartilage damage they sustained during the initial impact. It just feels like the most prevalent consequence.
It is entirely understandable why you would construct that clinical picture. Arthritis is highly visible.
Yeah.
It's deeply symptomatic, and it is what drives people to your clinic years down the line. But biologically and statistically, it's not the most common.
It's not.
No. The most common complication is avascular necrosis. It happens in up to 40% of cases. 40%.
40%.
Wait, 40%? That is staggering.
It really is.
Almost half of all posterior dislocations end up with dead bone. Let me just make sure I'm fully visualizing the mechanics of this.
Okay.
So avascular necrosis, AVN, means the blood supply to the femoral head is choked off, right?
The tiny retinacular vessels that wrap around the neck of the femur get violently stretched or torn when the head is forced out of the socket.
That's it.
Without that blood flow, the osteocytes, like the living cells inside the bone, literally starve to death, up to 40% of the time.
Yes. Most people vastly underestimate how fragile that blood supply is. The medial circumflex femoral artery is just incredibly vulnerable to being stretched.
Wow.
Let's lay out the full exact set of numbers so you and the listener have them permanently locked in.
Okay, right.
AVN is up to 40%. Arthritis is up to 20%. And that largely depends on the severity of the initial dislocation, whether the cartilage was sheared off the bone and whether there were associated fractures of the acetabulum.
Right.
Sciatic nerve injury is also up to 20%, and that specific risk rises significantly with a longer time to reduction. Finally, recurrent dislocation sits way down at just 2%.
Okay, I need to cement this. Let me repeat those. 40 for necrosis, 20 for arthritis, 20 for the sciatic nerve, 2 for recurrence. So 40 for necrosis, 20 for arthritis, 20 for the sciatic nerve, 2 for recurrence. And looking at those numbers and thinking about what we actually control in that trauma bay, if the sciatic nerve injury risk rises with the time the hip is left out of joint, then the sciatic number is the one I can actually change by reducing the hip quickly.
That is the single most clinically important sentence in this whole segment.
Really?
Yes. Time to reduction is the only variable you truly control.
Right.
The articular cartilage might have already been permanently gouged during the split second of impact, so the arthritis clock is ticking.
Right.
The retinacular blood vessels might have already been snapped or irreparably stressed, so the AVN clock is ticking. You can't undo that trauma.
But the nerve.
Exactly. But that sciatic nerve, it is currently being stretched over the dislocated femoral head like a rubber band over a bowling ball, minute by agonizing minute. Every second you wait, you're causing ischemic injury to that nerve.
That makes total sense. You put the patient to sleep and you pull that leg to get the bowling ball off the rubber band.
Precisely.
Now, if we flip this scenario, there's a common cognitive trap we run into when assessing these traumas, right? Where we imagine damage that isn't anatomically possible.
There is. So I want you listening to think through the 3D anatomy with us right now.
Okay, shoot.
Which of the following is not a recognized complication of a posterior hip dislocation? A posterior acetabular rim fracture, a vascular necrosis, femoral nerve injury, sciatic nerve injury, or chondromalacia of the femoral head.
Okay, let's reason through the physics of the injury. We just established AVN and sciatic nerve injuries are major common complications.
Right.
And the head is driven violently backward by the rugby players landing on him, so it makes perfect mechanical sense that it could smash off the posterior rim of the acetabulum on its way out.
Absolutely.
And chondromalacia, which is really just a fancy term for softening and damage of the cartilage, makes perfect sense from the blunt force trauma of the impact itself. So by process of anatomical elimination, the odd one out has to be the femoral nerve.
Femoral nerve, exactly.
Yeah.
And the reason is pure topographical anatomy.
Because it's in the front.
Right. The femoral nerve lies anterior to the hip joint. It's in the front, passing down through the femoral triangle, safely tucked under the inguinal ligament.
Makes sense.
A posterior dislocation drives the massive femoral head backward, tearing through the posterior capsule, moving entirely away from the front of the body. It is anatomically impossible for a posterior dislocation to compress a nerve that is running anteriorly.
I do want to flag something for you listening, though, because if you are reading along in some of the source texts or older research papers, there is a known, rather confusing typo out there.
Oh, yes. Good point.
Sometimes the text will read, the femoral head lies anterior to the hip joint. That is just a typo, right? It should say the femoral nerve lies anterior.
Yes, exactly.
The clinical takeaway remains the same. The answer is the femoral nerve, but don't let a stray typo in a textbook confuse your mental map of the human body. The head goes back. The femoral nerve stays totally safe in the front.
Good catch. Precision matters in anatomy.
Let's shift gears to a slightly different trauma patient.
You were consulted by the intensive care unit. They have a 28-year-old motorcyclist. He was in a devastating high-speed crash. He has a severe head injury. He's currently in a medically induced coma, and he's on a ventilator.
A really rough case.
Very. Orthopedics was called because he also has a major hip fracture. You pull up his medication chart, and you see he is being heavily dosed with indomethacin. Why?
Okay, well, let's look at the drug. Indomethacin. It's a very potent, non-steroidal anti-inflammatory drug. an NSAID.
Right.
We usually use it for severe gout or acute inflammatory conditions. But in this specific scenario, a massive head injury combined with major bone trauma, it is given to prevent heterotopic ossification.
Heterotopic ossification,
Yeah.
often just called HO.
Yeah.
It is the formation of actual mature bone in the soft tissues, the muscles, the fascia, where bone has absolutely no business being.
But how does that actually present clinically? Because when I try to picture bones spontaneously growing inside a muscle belly, like the quadriceps or the glutes, I immediately assume it must be excruciatingly painful.
You think so, right?
Yeah, I mean, the muscle fibers are literally being replaced by calcified rock.
That is the logical assumption, but it's completely contrary to the clinical reality.
Really?
It usually is not painful at all. It presents as a painless, progressive loss of movement. The joint just slowly turns to stone.
Wow.
That is the key discriminator. It catches clinicians out because they examine the patient expecting a hot, swollen, acutely painful hip akin to an infection or a flare-up of arthritis. Instead, it's quiet, it's cold, but it's completely stiff.
And what triggers it? Why this specific motorcyclist? Why does a head injury matter to a hip fracture?
This is a fascinating bit of systemic biology. There are very specific, literature-proven risk factors that trigger this process.
Like what?
A severe head injury or traumatic brain injury is a massive one. Prolonged ventilation time, spinal cord injuries, major burns, and amputations that go straight through the zone of injury in a blast-injured patient.
So it's not just local trauma to the hip, it's this massive systemic shock.
Exactly. When the body undergoes that level of systemic trauma, especially major neurological trauma, the humoral factors in the blood essentially go rogue.
Right.
The blood-brain barrier is compromised, inflammatory cytokines flood the system, and these chemical messengers travel down to the site of the hip fracture.
And what do they do there?
There, they inappropriately signal the uncommitted mesenchymal stem cells in the surrounding soft tissue. Instead of telling them to form muscle scar tissue or fascia, these rogue signals tell the stem cells to differentiate into osteoblasts and start laying down osteoid.
That is wild. So how do we stop it?
To prevent this cascade, prophylaxis involves indomethacin, bisphosphonates, and sometimes targeted localized radiotherapy to literally stop those rogue cells from dividing.
Oh, wow. Radiotherapy for a fracture.
Yeah, you only do surgical excision to the extra bone if the movement loss becomes totally debilitating, and crucially, only once the bone is completely matured and the inflammatory storm is passed.
Okay, here is where it gets really interesting, and there is a massive cognitive trap hidden in this clinical scenario that relies on us being a little too smart for our own good.
There absolutely is. The trap in the indomethacin scenario is that when you are presented with this case, you will almost always see a diagnosis option suggesting the indomethacin is going to cause a non-union of the hip fracture.
Right, and because you are an astute learner, you know the pharmacology.
Exactly.
You know that indomethacin is an NSAID, and NSAIDs inhibit prostaglandins. Prostaglandins are essential for the early stages of bone healing. Therefore, NSAIDs impair fracture healing.
Right, so your brain immediately connects the NSAID to delayed fracture healing. The biological fact you memorized actively fights the clinical reality of what is happening to the patient.
Yeah, you are being seduced by your own pharmacological knowledge.
You have to step back and look at the clinical intent. You must read the verb of the situation. You are being asked what the drug is given to prevent.
Ah.
We do not give a drug to prevent a non-union by using a drug that causes non-union. That makes no sense.
No, it doesn't.
We give it to prevent heterotopic ossification. Do not fall for the distractor of your own pharmacological knowledge. We're accepting a slight risk of delayed healing to stop the entire joint from permanently turning to stone.
Got it. Look at the big picture intent. Okay, let's distill this entire trauma segment. Give me the summary one-liner.
After a hip dislocation, necrosis is 40%, arthritis is 20%, sciatic is 20%, recurrence is 2%. Reduce it fast to save the nerve, because that's the number you can change.
Brilliant. Now let's move away from the violent trauma bay. Let's look at a much quieter, more insidious way a hip can die without the patient ever taking a hit on a rugby pitch.
Right, non-traumatic.
Let's dive deeper into osteonecrosis, but this time the non-traumatic kind. The hip hasn't been dislocated, it hasn't been starved by a stretched blood vessel, but the bone is dying anyway.
The vascular supply is failing from the inside out. Which of these has no etiological association with non-traumatic avascular necrosis of the femoral head? paracetamol overdose, HIV infection, excessive alcohol consumption, sickle cell disease, or long-term corticosteroids.
Well, the big classic three are famous. We see them all the time.
We do.
Excessive alcohol, long-term steroids, and sickle cell disease. So by elimination, it comes down to HIV infection versus a paracetamol overdose. And the answer has to be paracetamol.
Paracetamol. It is a potent hepatotoxin when taken in overdose. It severely poisons your liver, depletes your glutathione, but it does absolutely nothing to the blood supply of the femoral head.
Right.
Every other option on that list is a very real, heavily documented cause of AVN.
I have to admit, the HIV Association shocked me when I first came across it. I've studied the big three. I know how steroids, alcohol, and sickle cell cause microvascular issues, but HIV causing the femoral head to physically die.
Surprising, isn't it?
Yeah. How does a retrovirus attack a hip joint?
It surprises almost everybody, which is why you need to understand the mechanism because you will see these patients. There is a significantly increased incidence of AVN in the HIV-positive population.
But it's not the virus, right?
No, it's not driven by the virus itself attacking the osteocytes or the bone marrow. It is an iatrogenic effect. It's driven by a hyperlipidemia secondary to the use of protease inhibitors, the very medication used to manage the HIV and save their life.
Oh, wow. So the antiretroviral medication alters their lipid metabolism? The fats and lipids absolutely spike in the bloodstream, and then what? How does fat in the blood kill a bone in the leg?
It's a plumbing problem at a microscopic scale. You get vascular occlusion in the juxta-articular sinusoids.
Okay, walk me through that.
The femoral head is supplied by tiny, delicate venous outflow tracts. When lipid levels spike dramatically, these tracts essentially get choked with fat emboli.
Oh, so they just block it up.
The blood comes in, but it can't get out. The pressure builds up inside the rigid bone marrow space, which further chokes off the arterial supply, and the bone suffocates.
That's horrifying.
This specific pathology is more common in males. It's also often associated with underlying systemic coagulation abnormalities, specifically protein C and protein S deficiency, which leads to microthrombi.
So the overarching theme of non-traumatic AVN is microscopic blockages. Whether it's fat emboli from long-term steroids, fat from excessive alcohol, fat from protease inhibitors in HIV, or sludged, malformed red blood cells sticking together from sickle cell or tiny microclots from protein C and S deficiency.
Yes.
The end result is physically the same. The microscopic plumbing gets blocked, the blood stops flowing, the bone starves and dies.
Precisely. It is all about the microcirculation inside a rigid box.
So how do we actually catch it before the bone physically crumbles under the patient's body weight? Because if the bone dies, it loses its structural integrity.
Yeah.
If a patient is currently asymptomatic, maybe they are on high-dose steroids for lupus, and we want to screen them, what is the absolute most sensitive imaging modality?
Right. The word asymptomatic is the absolute giveaway in clinical reasoning. If they have no pain, plain X-rays will show absolutely nothing.
Because the structure is still there.
Exactly. The trabecular bone hasn't collapsed yet. What is the most sensitive modality?
It has to be a magnetic resonance imaging scan, an MRI.
MRI. It is highly sensitive and highly specific. It picks up the very early marrow edema. It shows the fluid shifts inside the bone and the early necrotic changes months or even years before any sclerosis, cysts, or structural collapse shows up on plain radiographs.
That makes sense.
But here is the bit that matters for you as a surgeon. An MRI doesn't just say AVN is present. It shows you exactly where the necrotic focus sits in 3D space, and it tells you if there is any associated articular cartilage degeneration overlying that dead zone.
Which is absolutely crucial for treatment planning, because you can't just fix it with a pill.
Exactly, because if you catch it early enough, before the mechanical structure collapses, you can perform a directed core decompression.
Oh, right, drilling into the bone.
Yes, this is an incredible procedure. You take a drill, you map out the trajectory based on the MRI, and you literally drill a decompression tract up through the femoral neck directly into the dead zone.
To let the pressure out.
By doing that, you relieve the intraosseous pressure that is choking the blood supply, and you create a physical pathway to stimulate new blood vessels to grow into the dead bone. You can only safely aim that drill if you have a precise MRI map.
Which brings us to another diagnostic trap, because when clinicians hear the phrase early sensitive imaging, a lot of people will instinctively reach for a completely different answer out of habit.
Yes. A technetium bone scan is the highly seductive wrong choice.
Right.
You were taught in medical school that a bone scan is the wonderfully sensitive early test for stress fractures, for silent infections, for hidden bone metastases.
But a bone scan is, well, it's sensitive but blind.
Sensitive but blind. It lights up. It tells you something is metabolically happening in that hip. There's increased tracer uptake.
But it doesn't tell you the geography.
Exactly. But an MRI tells you exactly what is happening, exactly where it is happening, and exactly how much bone volume is involved. A bone scan cannot give you a surgical map. Never choose a bone scan over an MRI for mapping AVN.
Let's shift this from adults to a different population, the pediatric side. Kids get avascular necrosis too, Perthes disease being the classic, well-known example.
Right.
But they are growing. They are biologically distinct. What is the actual cellular histological difference between avascular necrosis of the femoral head in a growing child versus a mature adult?
This is a fascinating bit of biology where our intuition totally betrays us. When you think of children and bone healing, what is your plausible gut assumption?
You just assume children heal better from everything. They have phenomenal remodeling potential, open growth plates, amazing robust blood supply.
Yeah, that's what everyone thinks.
If a kid breaks a bone, it heals in half the time of an adult. You think they would just bounce back from AVN easily?
Everyone assumes that. It feels right.
Yeah.
But biologically, it is the exact wrong shape of thinking for this specific pathology. The reality is that children show less creeping substitution than adults.
Wait, hold on. Less creeping substitution. But creeping substitution is the primary mechanism of bone repair.
Exactly.
That's the beautiful process where the osteoclasts bore away the dead bone and the osteoblasts follow right behind in their wake, laying down fresh, living, structural bone directly onto the old dead scaffolding. If kids have less of that, what are they doing instead? What is biologically breaking down in that chain?
It's not breaking down, it's an overreaction. Immature animal models and histological studies show us that the child's physiological response is different.
How so?
They mount a massive, aggressive osteoclastic resorption phase. They eat away the dead bone incredibly fast, but then it is followed by a huge fibroblastic response. They have very little organized, sequential, creeping substitution. Instead of carefully marching new bone along the old trabecular scaffolding like a mature adult would, the child's body aggressively resorbs the dead area, leaves a massive void, and just dumps fibrous tissue into it.
So they're essentially filling a structural void with scar tissue instead of structural steel.
Precisely.
So what does that mean for the joint clinically when they stand up and walk?
It means osseous collapse is incredibly common. The fibrous tissue has no compressive strength. It cannot support the mechanical load of running and jumping.
Yikes.
The femoral head literally squashes and flattens out under the body weight. Because of this, there are often long-term, permanent residual changes in the shape of the femoral head.
That's tragic.
Yes, children remodel their bones over time, but they do not simply heal back to normal. That spherical architecture is forever changed, leading to early arthritis in adulthood.
Okay, I need to lock this biological paradox in. Children have more resorption, more fibrous tissue, less creeping substitution, and collapse is common with lasting change in head shape.
You've got it. The child's body overreacts and replaces bone with scar tissue. Now, let's test your definitions with a quick related diagnostic puzzle.
Okay, bring it on.
All of these are classic examples of osteochondrosis, except D. Perthes, Scheuermann's, Osgood-Schlatter, Gorham's, or Blount disease.
Okay, let's categorize them. Perthes is the hip we just discussed. Scheuermann's disease affects the vertebral end plates in the spine.
Right.
Osgood-Schlatter is the apophysis at the tibial tubercle in the knee. Blount disease affects the proximal tibia, causing bowing. So the exception, the outlier, is Gorham's.
Gorham's, correct. And osteochondrosis is, by definition, a symptomatic disorder of cartilage growth and ossification in children, whether it's at the epiphysis, the physis, or an apophysis.
Right, they all fit that pattern.
Exactly. Gorham's disease is an entirely different, bizarre beast.
What actually is it?
It is a very rare lymphatic and vascular disorder. It's characterized by a massive, aggressive proliferation of vascular and lymphatic channels that literally wash the bone away.
Wash the bone rule.
The bone just vanishes on x-rays. It's colloquially known as disappearing bone disease. It is not an osteochondrosis. It is a proliferative vascular anomaly.
Disappearing bone disease. Amazing. Okay, summarize the dying bones segment for us.
Steroids, alcohol, sickle cell, and HIV cause AVN. MRI finds and maps it. The pediatric head resorbs and collapses rather than creeping back to normal.
Perfect. Let's do a rapid-fire recap of everything so far to make sure we haven't lost the forest for the trees. I'll take the trauma, you take the necrosis.
I'm good.
First, post-traumatic dislocation complications. AVN is 40%, arthritis is 20, sciatic nerve is 20, recurrence is 2.
Yep.
The femoral nerve is not a complication because it sits safely anteriorly. Heterotopic ossification presents as painless stiffness, not a hot joint. You give prophylaxis with indomethacin, bisphosphonates, or radiotherapy. The risk factors for HO are head injury, cord injury, prolonged ventilation, burns, and blast amputation through the zone of injury.
And for necrosis, the non-traumatic causes are steroids, alcohol, sickle cell, HIV via protease inhibitor hyperlipidemia, and protein C and S deficiency, not paracetamol. MRI is the gold standard investigation because it maps the exact necrotic focus for directed cord decompression. Histologically, children show more resorption and a fibrous response, with little creeping substitution, resulting in collapse with permanent change in head shape. And finally, Gorham's is a lymphatic disorder, disappearing bone disease, not an osteochondrosis.
Clean.
Yeah.
So we've comprehensively covered what happens when the blood supply dies, the hip starves. But now let's talk about what happens when the blood supply is fine, but the hip is structurally built wrong from a geometric perspective.
We are moving from vascular pathology to pure mechanical engineering.
Exciting.
Let's look at impingement. Simply put, too much bone. Picture a 40-year-old man in your clinic. He's complaining of deep, aching groin pain that has steadily increased with activity over the last year.
Okay, classic presentation.
He can't run as far. It hurts to sit in low chairs. On examination, he has restricted motion, and he is exquisitely tender when you combine flexion, adduction, and internal rotation. You pull up the radiograph, and you see early joint degeneration, some sclerosis, and a very distinct flattening of the head-neck junction.
That phrase right there, flattening of the head-neck junction, that's the diagnostic giveaway, isn't it?
It is.
When I picture a normal femur, there should be a nice, concave, sweeping ski slope from the spherical head down to the neck. If that is flattened out, it creates a pistol grip deformity, which indicates femoroacetabular impingement, specifically the CAM type.
Spot on. But let's break down the biomechanics of FAI femoroacetabular impingement. This was pioneered by Reinhold Ganz and the Bernese group, and it totally revolutionized how we view early hip arthritis.
It's brilliant stuff.
Give me the mechanical distinction between a CAM lesion and a pincer lesion.
So, a CAM impingement is fundamentally a femoral problem. The femoral head is supposed to be a perfect, smooth sphere rotating inside a cup. In CAM impingement, it is non-spherical. It has an extra bump of bone and abnormal prominence at the anterolateral head-neck junction.
Like an out-around tear.
Exactly. Think of how a camshaft in a car engine works. As the shaft rotates, the asymmetrical lobe pushes against the valve. In the hip, when the leg moves, that prominent out-of-round bump rotates violently into the joint.
Acting like a wedge.
It acts like a wedge. It generates massive microscopic shear forces that literally peel the articular cartilage right off the acetabular bone, delaminating it layer by layer. And on an X-ray, that extra bone makes the proximal femur look thick and blocky, like the handle of an old-fashioned flintlock pistol, the pistol grip deformity.
Exactly. The extra bone wedges into the joint. CAM is femoral. Now what about pincer?
Pincer is the exact opposite side of the joint. It's an acetabular problem, the socket. In a pure pincer impingement, the femoral head is actually perfectly spherical and completely normal.
Okay, so where's the problem?
The problem is abnormal contact because there is too much acetabular coverage. The socket is too deep, or perhaps it's retroverted, tilted backward. It acts like a literal pincer, crushing the delicate labrum, which is the cartilage O-ring around the socket, repeatedly against the normal femoral neck during movement.
CAM is a femoral bump wedging in. Pincer is an acetabular rim crushing down. And because this is so structurally specific, your clinical examination is critical to making the diagnosis before you even see the X-ray.
Oh, absolutely.
How do you elicit the impingement test in the clinic?
I would use the FADIR test. FADIR, flexion, adduction, internal rotation.
I want you to walk the listener through the actual 3D mechanical logic of that test. What are you physically doing to the joint surfaces?
Imagine the patient lying on their back. You take their leg in your hands. First, you flex the hip up to 90 degrees. That brings the femoral neck closer to the front of the socket.
Right.
Then you adduct it, bringing the knee across the midline of their body. That closes the space even more. And finally, you maximally internally rotate the thigh, twisting it inward.
Which does what to the bone?
By doing that specific combination of movements, you are taking that abnormal bump of bone on the anterior femur, the CAM lesion, and you are deliberately driving it directly into the anterosuperior margin of the acetabulum.
Right into the danger zone.
Exactly. That anterosuperior edge happens to be exactly where the labrum lives and where the labral tear usually is. When you forcefully crush those two damaged structures together, it reproduces their sharp, deep groin pain perfectly.
Excellent. You are mechanically recreating the impingement. Now, here comes the clinical trap.
Let me guess. It is incredibly tempting to use a different, very famous acronym test here because we use it all the time for hip pain.
It is. The clinical distractor is FADIR, flexion, abduction, external rotation.
Hmm.
It sounds similar, it looks similar in a textbook, and the trap is that FADIR is a very real, very useful orthopedic test.
But it tests the wrong thing.
Just test something completely different.
Mm.
If you use it to diagnose anterior impingement, you're going to get a completely false picture of the patient.
Right, because if I do FABR, I'm opening the joint up anteriorly, not closing it. So what does FABR actually test?
FABR primarily elicits posterior pelvic pain. By flexing, abducting, and externally rotating the hip, you are locking the hip joint and transferring the stress force directly to the sacroiliac joint in the back of the pelvis, or the lumbosacral junction.
Oh, I see.
The only caveat, the only rare exception, is in a patient with severe protrusio acetabulae, where the socket is unbelievably deep.
Like too deep.
Yes. Those patients might have lateral or posterior impingement, and in that rare case, pure abduction or FABR might reproduce their hip pain. But for your standard anterior cam or pincer impingement, it is FADIR.
What about other physical tests we should use to rule out other pathologies?
You must utilize the Tonnis test. That is used to unmask a fixed flexion deformity of the hip. A patient might look like they are standing straight, but they're actually tilting their pelvis and overarching their back to compensate for a hip that refuses to extend.
Oh, so they're masking it.
Exactly. The Tonnis test flattens out that lumbar lordosis and reveals the hidden hip stiffness. You should also use the active straight leg raise. That is a fantastic, simple screening tool.
Just having them lift their leg.
Yep. When you ask a supine patient to simply lift their straight leg off the bed, it generates a joint reactive force through the hip flexors of about twice their entire body weight. If they can do that completely painlessly, their hip is very likely free of major intra-articular pathology.
Okay, let's summarize the impingement mechanics so we don't forget the geometry.
Cam is a non-spherical head with a pistol grip. Pincer is a normal head against an overcovering socket. FADIR reproduces it by crushing them together, not FABR.
Got it. So that is impingement when there is too much bone causing mechanical collisions. But what if we have the exact opposite problem? Let's flip to developmental dysplasia of the hip. Not enough bone.
Right. The socket didn't form properly during childhood. It is shallow, the roof is sloping upward instead of sitting flat, meaning the femoral head is constantly trying to slide upward and outward under the body's weight.
Sounds unstable.
It is. Let's start with imaging, because you can't fix what you can't see. Which radiographic view is best for detecting anterior acetabular deficiency in a dysplastic hip?
If I'm looking at a standard AP pelvis, an anteroposterior view, I can see the sides, the lateral coverage, but I can't really see the front of the socket. To see anterior deficiency, the answer is the false profile view of Lekens and Desses.
Correct. But you can't just know the eponym. You have to know how it is physically executed by the radiographer. Otherwise, you can't interpret the image.
Okay, break it down.
It is taken with the patient standing up, bearing weight. The affected hip is placed directly against the radiographic cassette. The ipsilateral foot, the foot of the affected side, is parallel to the cassette. Right. And here is the critical number for the geometric alignment. The pelvis is rotated exactly 65 degrees from the plane of the cassette.
65 degrees.
65 degrees. It is the only view that accurately assesses the true anterior coverage of the femoral head by the acetabulum. No standard AP view will ever show you that anterior slope properly because the curve of the pelvis hides it. You have to rotate them 65 degrees to profile it.
I want to talk about angles, because when you look at these dysplasia x-rays, there are lines and measurements drawn everywhere, and it is incredibly easy to confuse them.
Yes, the geometry problem. Imagine you are presented with a radiograph of a 23-year-old woman with dysplasia symptoms. There's an angle marked on her radiograph. It runs from the true horizontal line of the pelvis up to a line drawn from the medial edge of the sorsal to the lateral edge of the sorsal.
Yeah.
What is that angle measuring?
Okay, let's break down the terminology first to visualize it. Sorsal is French for eyebrow.
Right.
On an X-ray, it refers to the dense, bright, white, sclerotic crescent of bone at the very top of the acetabulum. It looks exactly like an eyebrow resting over the femoral head. It's the primary weight-bearing roof of the joint.
Good visualization.
So if we are measuring the slope of that eyebrow against a flat horizontal line that is the Tonnis angle, it's also known as the acetabular index or the acetabular roof angle. If that angle is too high, the roof is sloping and the hip is dysplastic.
Spot on. Now, the trick in clinical diagnostics is keeping all these geometrical measurements straight in your head. How do you conceptually keep them all apart?
It's all about what specific geometric feature each one measures. You just said the Tonnis angle measures the upward slope of the weight-bearing roof. Then you have the Weidenberg angle, which is the lateral center edge angle.
Right.
Imagine dropping a plumb line straight down through the center of the femoral head and then drawing a second line to the outer edge of the socket. That measures the lateral coverage, how far the roof extends sideways.
Right. And if Wimber measures lateral coverage, what measures anterior coverage?
That would be the vertical center edge angle. That's essentially the false profile equivalent of the Weinberg angle. Then there is Sharp's angle, which measures the overall acetabular inclination starting down from the teardrops at the bottom of the pelvis. It gives you the big picture tilt of the whole socket.
Very thorough.
And finally, you have the alpha angle.
The alpha angle. Where does that one live?
The alpha angle measures the cam lesion. You draw a circle around the femoral head and measure where the extra bone starts bulging out. It lives entirely on the femoral side. Wait, alpha is the only angle on that whole list that is measuring the femur, not the acetabulum.
Exactly. The alpha angle is the only femoral-sided angle. If you remember that one single fact, you can eliminate it immediately from any diagnostic dilemma asking about acetabular dysplasia. That alone will clarify your thinking when looking at a complex X-ray.
That's a fantastic conceptual hack. Okay, let's move from reading the imaging to actually making a surgical decision. Here is the scenario. You have a 28-year-old woman. She has moderate daily hip pain that has worsened over a year. Non-surgical management, like physiotherapy to strengthen the abductors and NSAIDs, has completely failed.
Standard history.
She has no history of trauma. The X-ray shows clear dysplasia, a shallow socket, a high Tonnis angle. But the hip is reduced, meaning the head is still inside the socket, and it is congruent, meaning the curves of the head and the socket match each other perfectly, even though the socket is too shallow. What is the right surgical choice for her?
Your surgical toolbox includes simple observation, a Pemberton osteotomy, a periacetabular osteotomy, a Chiari osteotomy, or a total hip replacement. Which one is the right choice for a 28-year-old with a congruent, painful dysplastic hip?
The answer is a periacetabular osteotomy, or PAO, often called the Bernese PAO.
Why a PAO? What are you mechanically achieving?
Because it fundamentally improves the hip's biomechanics without replacing the joint. You make a series of complex bone cuts around the acetabulum, completely freeing up the socket from the pelvis, while leaving the posterior column intact for stability.
Right.
Then, you physically rotate that socket like tilting the roof of a house to give the femoral head better coverage anteriorly and laterally. It normalizes the load-bearing forces, dropping the stress on the cartilage, and prolongs the life of her native joint. But crucially, it must be done before severe degenerative arthritic changes set in.
Now defend the rejections. Why not the other procedures?
Observation is out because she's in daily pain, and observation does nothing to change the natural history. Because of the biomechanical overload, her joint will eventually destroy itself.
Very true.
A total hip replacement is out because she is only 28 years old. Putting a piece of metal and plastic in a young, active person means she will undoubtedly wear it out. She would face multiple complex, bone-losing revision surgeries in her lifetime. You want to save the native joint as long as humanly possible.
Excellent. And what about the other two historical osteotomies, Chiari and Pemberton?
The Chiari osteotomy is a salvage procedure. It's an extra-articular cut used for a non-congruent subluxated hip where the head no longer matches the socket.
Right, they don't line up.
Exactly. You basically cut the ilium and slide it over to create a new bony shelf over the displaced head. But our patient's hip is congruent. And a Pemberton osteotomy is strictly a pediatric procedure. It relies on bending and hinging the bone through an open, flexible triradiate cartilage in the pelvis.
Which she doesn't have.
Right. Since our patient is a 28-year-old adult, her triradiate cartilage fused into solid bone a decade ago. It is anatomically impossible to perform a Pemberton on her.
Perfect logic. The word congruent in your assessment actively excludes the Chiari salvage. The phrase 28-year-old actively excludes the pediatric Pemberton. You have to read the biology of the patient.
Right.
Now, one last point on dysplasia. There is a frequent clinical discussion regarding the outcomes of a Salter osteotomy, which is another type of redirectional osteotomy historically used in developmental dysplasia. What predicts a worse outcome for a Salter?
The long-term results of a Salter osteotomy are significantly worse if there is a higher degree of dislocation before the treatment, specifically as graded by the Tonnis system.
Correct. People often assume that factors like bilaterality, having dysplasia in both hips, or a higher preoperative acetabular index, or an older age at the time of surgery, are the main predictors of failure.
But they aren't.
None of those have been definitively shown to be predictive of a worse outcome in the same way a high Tonnis grade of initial dislocation is. Also, take note of this surgical detail. The result is actually better if the open reduction, putting the hip back in the socket if one is needed, is performed as a completely separate operation prior to the osteotomy, rather than trying to do both massive traumatic shifts to the hip at the same time.
That's a great clinical pearl. Time for the summary of segment 4.
False profile at 65 degrees shows anterior coverage. Tonnis measures the roof slope. Congruent young adult dysplasia gets a PAO, not a replacement.
Let's knit the mechanical problems together. I will seamlessly summarize the too much bone and not enough bone sections.
Go for it.
Impingement. Cam is a non-spherical femoral head with a pistol grip deformity, acting like a camshaft that drives shear damage into the cartilage. Pincer is a normal head grinding against abnormal acetabular contact from overcoverage. FADIR mechanically reproduces the impingement pain. FABR is an entirely different test for the sacroiliac joint. The Thomas test unmasks hidden fixed flexion.
And dysplasia.
The false profile view is done standing, with the pelvis rotated exactly 65 degrees, and it shows the hidden anterior coverage. The Tonnis angle measures the upward roof slope from the medial to the lateral sorsal, the eyebrow of the joint. The alpha angle is the only geometric angle on the femoral side. A reduced, congruent dysplastic hip in a 28-year-old gets a periacetabular osteotomy to rotate the roof. Chiari is a salvage procedure for non-congruent hips. Pemberton is out because it inherently needs an open triradiate cartilage. And Salter osteotomy results are proven worse with a higher Tonnis grade of dislocation.
Which brings us to the final destination, the end of the road, arthrodesis.
Fusion.
The operation nobody teaches anymore, but the one you absolutely must understand biomechanically.
B. Final salvage. When the joint is completely destroyed beyond the help of a PAO, beyond the help of core decompression, and for whatever reason, maybe terrible recurrent infections or lack of abductor musculature or extreme young age and heavy labor, a total hip replacement simply isn't an option. We fuse the femur permanently to the pelvis.
It is a massive, irreversible, life-altering operation. You are turning a complex multi-axial joint into a solid pillar of bone. And the single most critical factor in its success is the three-dimensional position in which you lock that joint on the operating table.
Because it's permanent.
Once the bone heals, it is set for life. So what is the appropriate geometric position for arthrodesis of the hip? Is it flexion of 45 degrees, abduction of 15 degrees if there is shortening, adduction of 0 degrees, external rotation of 25 degrees, or shortening the leg by at least 3 centimeters?
Okay, this is tricky, and I can see exactly why people get this wrong. If I'm thinking about a patient who has a completely destroyed hip, they almost certainly have a leg length discrepancy.
Right.
They are short on that affected side because the bone has collapsed. So the option to fuse it in abduction of 15 degrees sounds incredibly sensible. If their leg is short, abduct the hip to artificially lengthen the limb and balance their pelvis out.
That is a very clever, highly logical train of thought. And that is precisely the reasoning that ruins these patients' lives. The correct answer is adduction of 0 degrees, meaning perfectly neutral.
Wait, why is abduction so devastating? If it helps equalize their leg length and stops them limping as badly, why does it ruin them?
Because of the kinetic chain of the human body. When you fuse a hip, it completely loses all ability to flex, extend, or absorb the motion of walking.
Obviously.
Every single ground reaction force is now transmitted directly past the hip, straight up into the lumbar spine, and across the pelvis to the contralateral leg. If you fuse that hip in any amount of abduction beyond neutral, you permanently, structurally tilt the pelvis.
Oh, I see.
That fixed pelvic tilt asymmetrically loads the lumbar spine for every single step they take for the rest of their life. It causes devastating, intractable mechanical back pain.
So you solve their hip pain, but you completely destroy their spine in the process.
Exactly. You are robbing Peter to pay Paul, and Peter is the lumbar spine. Let's map out the full, correct three-dimensional position for a fusion.
Okay, give me the numbers.
You want flexion between 25 and 35 degrees. Why? Because this allows them to sit in a chair reasonably well, but it still allows them to stand somewhat upright without overarching their back too much.
Makes sense.
You want neutral abduction, meaning exactly 0 degrees. Never abducted. A very slight adduction is considered acceptable. External rotation should be minimal, no more than about 5 degrees, just enough for foot clearance. And because the arthrodesis procedure inherently produces some bone loss and shortening anyway from cutting the joint surfaces flat, you never ever shorten deliberately.
Now, you did flag a slight discrepancy in the source material and historical literature for this topic, right?
Yes, an honesty note for anyone studying the biomechanical history closely. There is a secondary body of literature that gives the ideal position slightly differently. 20 to 30 degrees of flexion, slight adduction of 5 degrees or neutral, and 10 degrees of external rotation. The literature disagrees slightly internally on the exact degrees.
So what on earth is the core clinical takeaway if the numbers fluctuate?
You focus on the parts they violently agree on, which happen to be the parts that matter biomechanically. Flexion is roughly around 25 to 30 degrees. Coronal alignment is neutral to slightly adducted. Rotation is minimal external. But the absolute key point, the one you must memorize and practice, is not the exact degree of flexion.
It's the abduction.
Exactly. It is that abduction is the position you must avoid at all costs.
Got it. So how bad does it actually get? Like, if we are doing this to a patient, what's the long-term reality?
Let's talk about the long-term sequelae of this operation. Because it is rarely done now, people don't realize the toll it takes. This brings us to the scar story. There is a landmark, sobering study by Callahan and colleagues. They took 28 patients and followed them long-term after their hip arthrodesis.
Okay.
The findings explain exactly why we fight so hard to save native joints. At long-term follow-up, about 60% had developed severe pain in the ipsilateral knee, the knee on the exact same side as the fusion. And the mean time to the onset of that knee pain was 23 years. A similar percentage, 60%, had developed significant life-altering back pain, and about 25% had pain in the contralateral hip from the altered gait.
Let me repeat those stats because they paint a really grim picture of the kinetic chain breaking down. 60% knee, 60% back, 25% other hip.
60% knee, 60% back, 25% other hip. It is a profound mechanical toll.
That's almost guaranteed failure somewhere else in the body.
This operation is historically often done in young, heavy manual laborers who have destroyed their hips in their 20s or 30s and who need to get back to heavy lifting, something a total hip replacement wouldn't survive. It essentially buys that young laborer 20 good, pain-free years to work, build a life, and feed their family.
But then,
20 years later, the kinetic chain sends the bill. It is a legitimate surgical trade-off to make, but only if you sat down with that patient and told them exactly what was coming down the line.
if the hip is locked absolutely solid and 30 degrees of flexion, how does the patient actually walk?
Well, ask the question mechanically and it answers itself. A normally functioning hip flexes to allow the foot to clear the ground during the swing phase of walking. A fused hip cannot flex 1 single degree. So what does the patient have to do instead to get their foot forward without tripping over their own toes?
If they can't swing through the hip joint, they must have to lift the whole pelvis on that side and kind of swing the straight leg around in a semicircle to clear the floor.
Exactly. The clinical terms are hip hiking, literally raising the entire hemipelvis using the trunk muscles and circumduction during mid-swing. They have to borrow the movement from the lumbar spine and the pelvis because the hip joint won't give it to them.
Now, some people might watch a patient with a fused hip walk into the clinic, look at that weird, lurching, dropping gait, and call it a Trendelenburg gait. But that's mechanically wrong, isn't it?
It is absolutely not a Trendelenburg gait, and that is a major diagnostic trap. A Trendelenburg gait is caused by abductor failure. The gluteus medius and minimus muscles are weak or paralyzed, so the pelvis drops downwards on the opposite side when they stand on the affected leg.
Oh, I see.
In a fused hip, the abductors might be completely healthy.
Oh,
The weird gait is purely a loss of mobility issue. It is a different mechanical problem, resulting in a different gait pattern.
speaking of those abductors, eventually, some of these patients with intolerable back or knee pain will come back to you at age 50.
That will.
They will ask if you can undo the fusion. If you can surgically take down the solid arthrodesis, cut the bone, and give them a total hip replacement to restore motion and save their spine.
You can. It is a highly complex revision surgery, but it is done. But there is one paramount, non-negotiable assessment you must perform before converting a fusion to a replacement. What is it?
I would assume it's checking those exact muscles we just talked about, abductor function. You have to know if the gluteus medius and minimus still work after being locked up and mostly unused for 20 years.
Abductor function.
Yeah.
Correct. And because they haven't moved the joint in decades, you can't just ask them to lift their legs sideways against resistance in the clinic.
How do you test it then?
You have to check it objectively, often via an EMG, an electromyogram, to see if the muscle fibers still fire. If the EMG shows the abductors are totally atrophied, replaced by fat and gone, you absolutely cannot do the replacement.
Why not?
Because if you do, you will convert a stiff, painless, stable hip into a mobile, weak, constantly dislocating hip, and you'll give them a massive, uncontrollable Trendelenburg gait to go with it.
You have to know you have an engine before you take the brakes off. You check the muscle before you free the
You
joint.
check the motor before you unlock the door.
Right, give me the final summary one-liner for arthrodesis.
Fuse in roughly 30 degrees of flexion, neutral or slightly adducted, minimal external rotation, never abducted, and check the abductors with EMG before conversion.
Incredible. We have covered a massive amount of anatomical, biological, and biomechanical ground today. We've explored the dead hip, the impinging hip, the dysplastic hip, and the fused hip. It is time to lock every single detail down permanently. Let's run the lightning round. I'm going to fire the questions. You give me the definitive answers. Ready? Commonest complication of hip dislocation.
Avascular necrosis, up to 40%,
Sciatic injury rate, and what raises it?
up to 20%. Longer time to reduction.
Which nerve is not injured in posterior dislocation?
Femoral, it lies anterior.
Indomethacin after head injury and hip fracture?
Heterotopic ossification prophylaxis.
How does heterotopic ossification
And loss of movement, usually painless.
which is not a cause of osteonecrosis, steroids, alcohol, sickle cell, HIV, paracetamol?
Paracetamol.
Why does HIV cause it?
Hyperlipidemia from protease inhibitors.
Best imaging for asymptomatic AVN.
MRI.
Pediatric versus adult AVN histology,
Less creeping substitution in children. More resorption and fibroblastic response.
which is not an osteochondrosis.
Gorham's disappearing bone disease.
Pistol grip deformity.
CAM impingement.
Impingement test.
FADIR reflection, adduction, internal rotation.
Faber tests what?
Sacroiliac joint and lumbosacral junction.
Which view shows anterior acetabular coverage?
False profile, pelvis rotated 65 degrees.
Angle from medial to lateral sorsal.
Tonnis angle.
Which angle is femoral sided?
Alpha angle.
Congruent dysplastic hip, 28, failed non-op.
Periacetabular osteotomy.
Chiari is 4.
A non-congruent, subluxated hip salvage.
Why can't you do a Pemberton in an adult?
It needs an open triradiate cartilage.
Salter osteotomy, worst result with.
A higher Tonnis grade of dislocation.
Position to avoid in hip fusion.
Abduction.
Ipsilateral knee pain at long-term follow-up after fusion.
About 60%.
Gait after hip arthrodesis.
Hip hiking and circumduction in mid-swing.
Key assessment before converting a fusion to a replacement.
Abductor function.
Brilliant. That is it. So we've spent 2 incredibly dense modules exploring every conceivable way a hip joint can fail. It's either violently traumatized, metabolically dead, mechanically impinging, developmentally dysplastic, or surgically fused.
Which leaves exactly one thing left to do with it when all else fails.
Replace it.
The next module is the total hip. And it is the most physics-heavy deep dive in this entire series, so I will warn you, now we are going to dive deep into engineering principles. We are going to talk about frictional torque, volumetric wear, and exactly why Sir John Charnley deliberately chose a tiny 22mm head for his revolutionary implants when much bigger, seemingly more stable heads were readily available.
I love when we get into the pure engineering of the implants, but give me one thing to chew on before we go. A thought experiment to work on.
Here it is. Imagine 2 completely different hip replacement setups on the bench in front of you. Setup A is a large 32mm femoral head sitting on a thick 16mm trunnion neck. Setup B is a small 22mm femoral head sitting on a thin 11mm trunnion neck. Which one of those 2 setups has the greater range of motion before the metal neck mechanically impinges on the rim of the socket?
Instinctively, you'd think the bigger head. The 32mm, surely, because it has a larger radius to travel.
They are identical. Work out the geometry of Y before next time, and you will have understood the single most elegant mechanical idea in arthroplasty.
Module 3.
Bring a calculator.
Ortho Sapiens lower limb pathology. Module O2 of O9.